started.
Hello everybody. Thank you for coming for today's presentation. Today's topic is metastatic lesion with unknown primary, METs with unknown primary. So a small disclaimer, these are my opinions and only meant for teaching. So many times we come across a scenario like this. A 50 to 60-year-old gentleman or woman comes with a severe radiating back pain, weakness of both legs, and the A&E calls us and says there's a back pain with cauda equina syndrome, and we all think of a disc prolapse which has been causing this. And when we have MRI scan done, we see something like this. T2 weighted images shows a lesion in vertebra, destroying it and compressing the thecal sac, and we think of metastasis. Another diagnosis can be infection. However, as disc spaces are preserved, it's more likely to be metastasis, and that's what we are going to talk about. Maybe insidiously or acutely, and 2-3 days since you cannot really walk, there's weakness of leg, you find localized tenderness, you find objective loss of power, and most of people think that this might be a problem coming from a disc prolapse. However, if the age is like this, like around 60-65, with no history of back pain, no history of radiculopathy, one of the things which you should really suspect can be a metastatic lesion in spine. You won't be surprised to see a picture something like this. You can see the T2 images of MRI scan. There's a destruction of vertebral body, and the mass is actually pressing on the spinal cord, which can cause loss of power. It's emergency. Now, at this point, I would really like to tell you the diagnosis which you should have in mind. It can be either a malignancy, which can be usually metastatic or secondary, or it can be an infection, which is a differential diagnosis. We'll come to that later. So when you see a metastasis in a over 40 to 60 years age group, usually there are some common sites it's coming from. In men, carcinoma of lung is very common, the commonest site. In females, it's a breast. Other common sites are kidney, prostate, thyroid. Many times we cannot find where is the primary, and we have to work on the secondary lesion to get the primary. So sometimes you cannot find the primary lesion, and this is possible in around 10 to 15% cases. Lymphoma is really a diagnosis which is not really well diagnosed in elder population. It's more commonly in middle age. So that can be also a cause of malignancy or a skeletal lesion. So when you see the metastasis, how does this happen? So you got a tissue like breast or lungs with a tumor sitting in. So after some time, a part of tumor breaks away from the lesion and goes and enters the blood cell and blood vessels, and blood vessels carry it to the bone and seeding the lesion there and causing proliferation of cells, and then the metastasis, and then it's sequelae. So you can get lesions which are osteolytic, appearing as radiolucent areas. You can see this is a pelvis X-ray which shows the multiple osteolytic lesions. Osteolysis is a common sequelae of a metastasis because of there is a mechanism. However, there is a possibility that this metastasis can be also osteoblastic, which is appearing like a radio dense lesion in the bone. This is one of the picture to show how it appears. It has got differential diagnosis. This type of metastasis is possible with a prostatic carcinoma. The mechanism is not really well known, but there is a uh, hypothesis that endothelin 1 is responsible for osteoblastic proliferation and osteoblastic lesions. The osteolytic deposits uh, in the bone are well understood. You got a bone uh, microenvironment here with the trabeculae and some osteoblasts sitting there. And then suddenly the tumor cells come there and they secrete number of chemicals. Important of this is a PTH related peptide, interleukin, some tumor necrotic factor. And these work on the osteoblast. And osteoblast then secrete rankle, which work on the osteoclast, which causes osteolysis. So this is about osteolytic bony lesions. The osteoblastic, as I told you, is not really it's poorly understood and is related to a hypothesis is the chemical secreted is endothelin 1. So how does the a metastatic or bone tumor present? Pain is one of the very important characteristics. Pain has got various characteristics when it comes to tumor. The type of pain which is described in bony tumors is called deep boring pain, which is continuous. It can be progressive. It can be sudden increase if there's a fracture. It is severe and unremitting and aggravated by straining, that it becomes more when you try to move the limb or stress it, etc. And most important is nocturnal. Now, one of the very important thing is if the person is getting continuous deep boring pain and suddenly it increases to a sudden sharp pain, then you should suspect that there's a fracture or there's a collapse of structure. What are the other features of metastatic lesions? Pain, as we have gone through, pathological fracture also I mentioned. If it is spine, then there can be paralysis, which is paralysis can be of legs, of bladder, and etc. There is often weight loss and generalized cachexia. Weight loss is more common. Cachexia occurs at terminal stages. One of important thing which occurs is because of osteolysis. There can be hypercalcemia and its sequelae. Similarly, there can be coagulopathy and its sequelae. Right. So when you get a lesion, when you come across a lesions which look suspicious, so there are guidelines which we need to follow. The guidelines are often complicated, but the essence of the guideline is important. So in initial diagnostic phase, you are in clinic, you take a detailed history. When we say history, we have to ask history, which is onset, duration, progress of the problem. And second part is history of risk factors. So if you really squeeze history in orthopedics, this is history you have to ask. So when you say comprehensive history, history of risk factors is important. You have to ask history of any primary cancer and ask specifically, it's got any lumps in breast, any cough, or any jaundice, or difficulty in urine in, say, prostate area. And then physical examination. Physical examination, we tend to just examine the part which is presented to us and then really don't do a good systemic examination. But generally, we should examine the patient from head to toe if there is suspicion of malignancy. We are not expert, I know, in examination of chest and abdomen and prostate or breast, but this is what we need to do in the sense as a team. If we cannot do ourselves, we can take help of some other people. Then we have to do Xray next, I'll come to that. NICE recommends doing this investigation as a primary thing, like full blood count, urea, electrolytes, creatinine, liver function test, bone profile, calcium profile, and lactate dehydrogenase, which is considered as a tumor marker. It is a marker of intensity or the severity of malignancy. Once we have X-ray done, X-ray will show features of the malignancy, which I'll come to that. We need to do MRI of the part and CT of chest, abdo-pelvis. Some other recommendations which can be done as a group is this following investigation: myeloma screen if the lesion is multicentric, and some tumor markers like PSA, CA125, alpha fetoprotein, and if there are special suspicion, then ultrasound and biopsy. So what does X-ray really show? So this is very important. X-ray feature of malignancy is, unless it's a osteoblastic lesion from prostate, it shows a radiolucent lesion. Okay, you need to also tell what is the matrix like, where is a fibrous ground glass like, or it is a cartilaginous, etc. But usually it's radiolucence. And until 40% of calcium is lost from the bone due to osteolysis, this lesion doesn't really appear. So if it has appeared, that means itself that it has been there for some time and it has spread. And permeative margins. These permeative margins are the margins of lesions are merging with the normal, which means the zone of transition is very broad. There can be associated fracture or endosteal scalloping. So if you see the endosteal surfaces of a long bone, you'll see the smooth lines or smooth zones. Sometimes the tumor eats the bone from inside, that is from endosteal side, and that can be endosteal scalloping. So generally, when we got a suspicious lesion, we have to initial phase, all these guidelines tell us to discover three things. Number one is the origin. They want us to know whether it is a primary or secondary. Now, some tumors can show a characteristic feature, but most tumors in over 60 or over 40 age group can be secondaries. So secondary is focused on more here. Second thing we need to know is the stage of tumor or stage of the disease. Is what is the spread of the tumor. When there is skeletal metastasis, it itself tells us that is spread, but we have to also see how much is extraskeletal spread of the tumor. Stage is meaning of stage is meaning how much is spread, which is how much tumor is spread across. And third thing we have to see is grade, which shows us whether the tumor, how severe is the tumor, in the sense what's the grade. Histologically, if you ask histologists, grade means the level to which it which identifies with its host organ. So a poorly differentiated is more severe or more serious problem. All right, so next slide, we'll go there. As I said, MR is very important because it shows the lesion and the soft tissue element. Sorry for that. And CT scan is important. Number one, to get the diagnosis, and number two, to detect the extra skeletal metastasis. So you might find patient might have a CA breast and got some lesions in the chest and in lungs and in liver, etc., etc. So MRI of part and CT of chest, thorax, abdomen, and pelvis. This is important. Now, there is always a role of biopsy. Now, when we're talking about secondary lesions, the biopsy is usually done by oncologist with the help of radiologist. However, just to summarize, for tissue diagnosis, that is to establish the first two things, which is origin of the tumor as well as the grade of tumor, we can use operative biopsy, needle biopsy, commonly used, CT-gated biopsies, image-assisted biopsies like ultrasound or CT guided, and scope endoscopic biopsies. And sometimes if people suspect CA colon, there are brush biopsies, a number of them. But what we need to mention in exam, which can give you 6 for sure, is this. So you should always say, I would manage this patient as with multidisciplinary team approach. Now, if you see the multidisciplinary team approach, we got ourselves, we got oncologists, we got pathologists, we got the radiologist, we got nuclear medicine people, and all the people sitting together, and the patient. We really, actually, if you in your routine practice, you don't have to really interact with all of them. But most important person or persons you should be really in touch with, which can give you a chance of not missing out things, are these two people. There is always a MDT coordinator in each and every trust. And if you just call the switchboard and say, put me to MDT coordinator, and most of them are quite cooperative, and they allow transferring, and they help in transferring images and clinical data to the MDT team, which is located in district hospital, and get investigations. So this is most important. So you have to talk about the MDT approach, and you have to talk about the MDT coordinator, and always get hold of patient and details, develop a good rapport with them, and it will solve most of problems. Right. So if you really squeeze the management of solitary lesion, you got a suspicion, you do assessment, clinical and radiological, confirm the diagnosis with biopsy or imaging, and treatment. Treatment of a malignancy is again multidisciplinary. But what we as a surgeon have to do is to start with the basic level of management and then go to further. So first thing is, patient is in pain, he needs analgesia. So you give analgesia. Now what analgesia is required? We got a nice ladder by the WHO, which I'm putting. You start with the lowest and then go to highest, which is opioids. Most of the cancer patients do require opioids. So that's the most important thing. So just to summarize, I'll tell the ladder. The lowest, level 1, is a non-opioid like paracetamol, NSAIDs. 2 is with opioid, and 3 is a strong opioid. Now, so there are some teams in the hospital which can also do alternative methods of pain management if you get in touch with them, which are anesthetic doctors who go forth with the pain clinic. You've got a pain clinic, they do different types of blocks and ablation, etc. Now, NICE recommends using bisphosphonates for osteolytic lesion and denosumab for a lesion which comes from a solid tumor, the metastasis coming from solid tumor, especially if the vertebral involvement is there. This is basically to reduce pain as well as further fracture risk. And radiotherapy, again, this comes in, this is given by the onco team, MDT team. We can give radiotherapy as a pain modality. Now, as a surgeons, we are not really, there is already a team there, which is going to see all other aspects of diagnosis and all. What we come across is the lesion. What you're going to do with lesion on the limb. I'm coming to limb first, and then I'll go to spine. So when you see a suspicious osteolytic lesion and it's confirmed that it's metastatic, so you have to know whether it's a lesion or it's a fracture. If it's a lesion, is there a possibility of this lesion causing fracture, which for which we are needed? So we got some wise people got criteria there called Mirrell's criteria, in which you can quantify the possibility of prophylactic fixation. So you see about site, pain, lesion, and size, and you got a score. If score is more than 8, then patient really requires prophylactic fixation. So I'll not go into depths of it. Second thing is the patient has come with a fracture, pathological fracture with the lesion. Then again he needs a fixation. So you got a lesion or lesion with impending fracture or pathological fracture. Number 2 and 3 requires a surgery. Why is surgery, a prophylactic surgery, better than the surgery done after it fractures? Is because there's a lesser blood loss. You can dissect it better. Your recovery is fast. Your mobility is fast. There is a pain relief, which is an advantage. Now, if one of the really important thing is a lesion to really fix, to avoid the prophylactic, to avoid the fracture, you have to also consider the other aspects, like how bad is the cancer, what is the spread of cancer. The most important thing is a life expectancy. People recommend that if it's less than 6 months, usually no fixation or no replacement is done. So when you say fixation, we do for long bones or diaphyseal places, we do fixation with nailing and sometimes with plating. If it's near the joint, we do endoprosthetic replacement like this. This is in shoulder or hip or sometimes in knee when we do hinged knee replacement. In spine, spine has got complex variety of implants which we don't really come across. But if one word to really describe the spinal operation is decompression and stabilization, and it expresses what we're doing, and it also gives us the principle. So you can see the pedicle screw fixation in this case. So if the lesion is in spine, so it can be either a incidental finding or back pain. The first case which I showed you, a patient came with a severe back pain with the weakness of legs, or it can come as a fracture, a compression fracture, which is not really typical osteoporotic, shows some features, or it can come with neurological deficit. These are various ways the thing can present. So what do we do first? First thing is the one which I told is comprehensive history, examination, MRI of the part, and CT PA. But also when the lesion is suspicious, you make him, give him bed rest till we assess him further. If it's in cervical spine, give him neck collar and provide him analgesia and DVT care because there is hypercoagulopathy. NICE recommends a dose of corticosteroids, 16 milligram, if there is a cord compression. So it's important in diabetic people, you have to monitor the blood glucose levels. This dose is tapered over 5 to 7 days till we got definitive thing coming in, either surgery or radiotherapy. So when you say surgery for spine, many times you got a lesion in spine, and we wonder whether this will go for just analgesia or a shot of radiotherapy for pain relief, or it needs surgery. So we got some criteria called norms. So the MDT and the spine surgeon looks at these things. One is neurological status, most important. If there is neurology, it gives high marks to take him for operation, which is decompression with stabilization. Oncological, to see rate and responsiveness to radiation. Then we see the stability of spine. Did the tumor caused a sufficient instability and causing collapse of spine? There is a SIN score available. I'll put it up for that. But also important thing which you should mention in the exam is to see how is the functional physiological level of patient. Okay, uh, so I put the score which got various criteria like location, pain, type of lesion, alignment, if how much is collapse and how much involvement of posterior elements. So this is calculated by spinal surgeons and then consider whether they are going to go for operation. So generally, a decompression stabilization is done only for two things, and I've just added the third thing. So for all the spinal problems, if the lesion or a fracture or a degenerative process is operated on, it's only because of two reasons. One is uh, instability of spine and neurological deficit. Okay, which is progressive. This stands for everything. Severe back pain sometimes is also an indication if this is something like the spine has reached a stage where it cannot hold in and we need to something stabilize to get rid of pain. Again, here we have to have a proper life expectancy more than 6 months, otherwise the care is just palliative. So what is non-operative? You got a lesion which you don't want to operate because it's advanced. Then you just do palliative care, pain management, keep him comfortable, etc. Uh, one of the things when you calculate or you think about whether you should give non-operative, that is in other words, end of life pathway, depends on, there's a scoring system which takes various things in consideration called Tokachi scoring system, which tells us patient is not going to really go very far, so no point in doing much. Or some lesions can be treated with the radiotherapy, but this is Tokachi score, which shows number of lesions and number of metastases, skeletal and extraskeletal, and type of malignancy and what pulsates it has caused. You need to know it, but I don't think really you need to know details about it. And radiotherapy is basically done for a stable lesion, which is not causing any instability, neither any neurological problem. Radiotherapy also is if you ask radiotherapists, they say it's quite potent analgesic. Now, this I'm just mentioning just for completion. So some very enthusiastic people can also do vertebral osteoid kyphoplasty. I've just put it for completion purpose. But what basically they do is if there is a lot of kyphosis, they inject substance in the vertebral canal to build up the height. Right. So if it's spine, you should always talk about neuro rehabilitation of skin to avoid pressure sores, nutrition and hydration, respiration to prevent any chest infection with help of physiotherapist, and look at his bowel and bladder. Bowel and bladder care is also important. And one thing which are not really put here is a psychological. You should have psychological assessment available. Patient wants one, and I think MDT team has a specialist oncopsychologist. So if you really see, one of the thing question is like was what's the average survival? If see thyroids with skeletal metastasis nearly 48 months, then prostate 40 months, breast 24 months, or the CA lung is most problematic, which has got a very short average survival. So rarely we get people who got a lesion, we search everywhere, there's no sign of it. So there is a primary which is really unknown. Nobody knows about it. So we have to biopsy the lesion of the bone to get diagnosis, because the biopsy, the lesion has got a primary cell, not really the osteoblast and osteoclast, to get the diagnosis. And this is what is done by the MDT team if they are unable to find the primary. So these are two guidelines you should really use, but you cannot remember each and all point. So most important is summary. Summary is very simple: suspicious lesion, good history and examination, X-ray, MRI of part, CT scan, and MDT approach. And last but not the least is if there is an impending fracture, or cord compression or mechanical instability of spine, surgery. Thank you for your patient listening, and it was really a pleasure talking to you.
Thank you very much, Sid. That was very comprehensive. I think you've covered it and then some a bit. Fine, some questions here. One question was about the histology slides. Are we expected in the exam to know about the histology features of all these tumors?
Well, I wouldn't say you should know the exact histological features, but basically what you should tell examiner is if it is a metastatic lesion, then cells will be epithelial. Well, if it is a bony lesion or primary, then it will be non-epithelial or mesodermal. Okay, and like a fibroblast, which is coming from mesoderm, or third, it can come from lymphoid. So the three cells. So you can say if it's metastatic, we'll get epithelial cells there, or if it is coming from bone itself, we'll get a mesothelial cells. But I don't think you need to really tell about his exact histological features.
I think the question was, some people have been presented with histology slides and they are expected to comment on them. How far do you need to know about these slides? Are you expected to diagnose the tumor just based on the slides?
No, definitely no. What it is a starting question, okay? You are not a histologist at all, and you cannot diagnose any of them. But you can tell him this is like, for example, these are epithelial-looking cells with hypochromatic nuclei and something like this. So you can say there are or intent features. I don't know what it is, and then he will give you the second clue. But I don't think out of 100, only maybe 1 or 2 who has really gone through the slides will be able to make out some 0.5%, because even the histologists, they use other modalities like immunohistochemistry to really diagnose it. I don't think we should diagnose, but we can say this is epithelial, non-epithelial. That would be a thing.
I think it
obviously
is.
Sometimes there can be giant cell. You can see there's the multinucleated cells. This can be something like that. Some clue will be there, but I don't think even you don't answer that, they will. You can get around 7, 8.
Yeah, I don't think they will fail you if you don't recognize a particular type of tumor on the histology. It is part of the picture, but I think what they expect you to know is the basics about the histology, like hematoxylin iosine, and then that either there is like bony cells and whether there is hyperchromatoin in the cells, which indicates tumor. I don't think anything beyond that. Sometimes like fibrous tissues, you can recognize them sometimes by their fibroblasts, recognizable shape. But other than that, I don't think they will expect you to know more.
One of a very important tip I want to give to candidates is many a time the answer to this is very easy. Like you say, this is suppose you got a histology slide which you don't know anything. So you'll ask me what you'll do. Answer is very easy. I'll ask the histopathologist. Okay. Similarly, if there is a patient who's got and it's a quite good answer actually. Nothing you can. I mean, that's what we would ideally do, isn't it?
Yeah.
So I think this is, or what you like to do, I'll ask patient and explain him this thing. That's also quite a good thing.
Perfect. Now, just there are some other questions, and I encourage people to use the chance to ask any questions about the secondary mets in the bone. Having said that, we have got other series about the bone tumors lined up. So if you have anything about primary bone tumors, either malignant or benign, please hold your horses, because there is a series of talks about it. Now, another question says, what about kyphoplasty in spine mets and vertebroplasty indications? I think what they want to know is when each one of them is indicated. I think this is slightly beyond this, but...
this is beyond really syllabus of FRCS. It's a FRCS question. Now, if there is an instability, neurological deficit, and then it's definitely not vertebroplasty. That it means decompression with stabilization. I think a stable lesion which causes curvature problem, like kyphosis, is the lesion which is treated by vertebroplasty, whether it's metastatic or whether it's osteoporotic.
Mm-hmm. I think the standard answer in this will be, as Sid said, it's mainly decompression and stabilization. Kyphoplasty and vertebroplasty is mainly for pain relief, but for FRCS, your answer should be decompression and stabilization for the spine.
Yeah.
Okay. Good. I will use the chance to remind everyone about our website. We will put a link to it on the, Amjad, if you are kind enough to put a link up to the website. Just to remind you, we've launched our website, and you will find a lot of the teaching sessions about us, about how you want, communicate with us on that website, and a link to some very useful resources and websites. In addition, to remind you again about the book, which is a summary for the exam. It's, as it says, notes about the FRCS exam. As many of your colleagues have mentioned, it is very useful to revise last thing before you go to the exam, or use it as a base so that you can cover the syllabus. And it is a project not by us, it is by all of us. So any remarks you put, we will immediately look into added them to the next edition. And the work on the next edition has already started. And we want you to be our editor. So we want you to look at the book and let us know if there are anything that is missing, that needs adjusting, or that needs explaining better. And one more thing, people who've got the book, please write your testimonials, whether good or bad. Obviously, we prefer the good ones, but we want honesty as well, so that people who to buy it, who needs it, not anyone. As I said, there is no financial reward to us whatsoever from that. We've tried to make it as cheap as practical. It's just to cover the cost of it, and all the work we've done is for free. Thank you, Amjad. You've got the website there. And as I said, there are some very important links and resources in there. Now, going back to the questions about the talk, Abdul Jabbar asks how urgent you will operate on a first case presented. I think let's summarize, let's separate it, because if it's a limb is something, and if it's a spine, it is something else. Yeah. If it is fractured already, it's something, and if it's not fractured. So how would you address that, Sid?
So, for example, we'll take limb first. Mm-hmm. So there are first a possibility is a lesion with impending fracture as per Miller's code. Okay, you can do it on an elective list. Okay, but give him immobilization, pain relief, and keep him non-weight bearing, etc. If there's a fracture, then again, after you have a MDT team approach, next trauma list, isn't it? Now, this is about limbs. If in the spine, if it is causing a cord compression, cord or cauda compression, then you have to take him immediately to theater or as a urgency. If it is instability, then I think it should go on next trauma list. What do you feel?
Amjad?
Yeah, so regarding the limb, I think very important part is the implant should outlive the patient. Because this is a very important thing. A lot of people, they say this is an impending fracture, you need to go and fix it as urgent, and you fix it with a nail, while it was like, you find it out, it turned out to be a primary. It's very, very, very rarely can happen. People have been caught with this. To be safe, yes, you need to say, this is an impended fracture, I need to fix it as soon as, but as Sid was saying, it's very important to get involved with the MDT. Regarding the spine, for the spine, neurology is the main kind of the main mover towards the surgery. If there is a neurology, especially an evolving neurology, you need to intervene quite urgently. But some people, there is a lot of debate. Some people, they say, if it happened over like in the middle of the night, you can, some people, they say, you can give, sometimes you can give a steroid. It's a lot of, there is a lot of debate around this. To be safe, you will say, I will intervene urgently. And that's your answer for the FRCS, to avoid any controversial topics.
About 2 weeks, the most trust for non-urgent things has got a 2-week pathway of investigation. That's what I think the comment says there. Which, like, suppose you got a suspicion and you want to get an urgent MRI, the 2-week pathways to sort out the investigation and come up with a plan. This is for non-urgent things. And that's what the clarification for the comment.
Okay, now may I ask everyone to mute, please, so that we give as much broadwidth to Xray. Okay, Xray.
Now, I was just about to create some stirring and controversy for whatever Sid and Amgad said a minute ago. So imagine if you've got the, I know I joined a bit late. I know the topic is about unknown primary. So you get a patient with a, say, query impending cord compression with a metastatic cord compression. What would be mentors, primary for mentors? So would you go intervene and fix it, or decompress and fix it straight away? Or would you want to know what the primary is? The reason I'm asking you is, if you have a renal met, you're going to have a patient who's going to bleed on table, bleed to death. Or if it is a myeloma, you're not going to intervene at all. You're going to stir it with radiotherapy and kill it. So whenever I practice intensely with spinal surgeons, I've always come with this topic. I personally, unless it is, would say, for the safety of the patient, there is some situations where you need to be absolutely certain, because if you've got a renal met and if you're going to go and deep compress, there's a chance that the patient could bleed to death on table. And suppose myeloma, you do not want to decompress the myeloma, because if you're going to give radiotherapy, you're going to clear myeloma. So there is a bit of ifs and buts here to know the primary before you go and fix it or decompress it. That's what it's about.
I'll give to Sid, please. Can I ask Sid? He's the presenter. Yeah. Okay, Sid, what would you answer that? Sid, you are on mute, sorry. Can you say that again? Yeah.
So if the patient is come with the metastasis of the spine and he's got a mechanical instability of spine and a neurological compromise, okay, like cauda or cord compression. Now, I do believe that we need to know whether it's coming from kidney or not. That's a cash question. So we are going to organize an urgent MRI also, because this is a serious problem, and a CTPA and that should really show the tumor, because if there's no tumor in kidney, then I think we really cannot say that's a renal thing. So these investigations I think are important. Even in the middle of the night, you can get them done.
Okay, Amjad? Yeah, so I work in the spinal unit. Most of these patients, we have actually the answer, the safest way is to say we have the MDT. We usually get the MDT, and the MDT involving the oncologist and the radiologist. And in the survey, we will start the MRI whole spine and then we get a CT tab, especially if there is unknown primary. Biopsy is, if there is unknown primary, we'll definitely usually go for a biopsy if there is nothing showed up in this investigation. So there is no huge rush, even if there is an neurology. There will be very important, especially if there is, the primary is suspected is a renal cell. You are going to actually lose this patient on table from bleeding. So the safest way is to say I would go for for MDT, especially if there is a renal cell tumor. I know there are catches there. They try to push you in FRCS. They try to push you towards in the middle of the night, and this kind of catching scenarios. I think try to be safe rather than jumping into the answer.
I think the neurological symptoms secondary to tumor are slightly different than, well, more than slightly different than acute compression because of cauda equina secondary to disc or secondary to trauma. The reason is there is a reasonable response to steroids. So your first line of management could be steroids to try and reduce the edema, and by reducing the edema, you are reducing the bulk pressure on the cord. And in that case, you buy yourself a little bit of time to investigate. So I think it is very safe to say it is urgent. However, I would like to exclude a dangerous primary tumor. Hence, I will, through the MDT meeting, urgently, I will arrange for some steroids to try and reduce the edema. And by doing so, I'm reducing the compression on the nerve, and that would recover some of the nerve function, and use this valuable time to investigate the primary and do the tumor surgically as soon as we've got more information. The other thing is, if the patient has widespread mets and the prognosis is so poor that the patient will not survive the surgery, again, that's a thing that you can throw in the mix and make things even more complex. So the guidelines, well, not the guidelines, the principles are you be safe. You don't want to kill the patient during the operation, and it is very fair to say, I don't want to operate until I know that it's not thyroid and it's not renal. As I said, it's not trauma where you have to intervene immediately, I mean.
Yeah, this is important. Steroids is a very important point, actually.
I think,
yes,
Abdullah, I think you will have to bring, I think the guideline is a nice guideline for metastatic cord compression. That's the buzzword to bring in very early.
Absolutely. Absolutely. And I think we've got a summary of it. Sid has mentioned a summary of it, and we've got a link to that. Okay, let's move on.
There is another question up.
Sorry, say again, Amgad.
There is another question.
Yes, I was going for that. If you have multiple deposits and the 1 year is unknown, what is the 1 year? I think it's mean the survival or the prognosis. Sorry? Primary is known. Do you still have to biopsy or not?
Well, if the primary known,
and you've got multiple deposits.
Yeah. So if there is if you know the primary is, and you're thinking whether it's either a secondary metastasis or it's something else which has come. This is again to be discussed in MDT, because it's just not like a MRI and this thing which will show. Probably most people would like to get a biopsy of the lesion, whether it's not, if it's coming from the same as the same metastatic chain, or it is something which has come de novo. Okay, so once you say MDT, and I think that it requires a biopsy of lesion, I think that's quite a reasonable answer.
Would you delay the operation to get the biopsy? That's the question, probably.
If it's 1 year old and
sorry, that's not 1 year old. That's me misreading the question. Sorry, it's not 1 year old. Sorry.
Okay.
Yeah. So would you delay the operation?
Delay the operation
until you get the biopsy.
You mean if it's spinal? Is that?
It's not. It's not very clear actually. It says you've got multiple deposits. Let's assume that it's a limb. Okay. So you've got multiple deposits in limb, and
primary.
And you know the primary. Would you delay the operation until you do a second biopsy?
Well, I don't know is a frank answer. I would point out to MDT.
Amgad, you're working, and Xray, Hani, Mustafa, any of you?
I think.
Xray, you are on mute, sorry. Yes, Hani. Or was that Mustafa?
I think what I know that if you know the primary, like patient with cancer breast and she has metastasis, but the patient treated from the cancer breast, you don't know is this from cancer breast more or maybe multiple myeloma. So even if you know the primary, you have to do biopsy. There is no any pathologist, there is no any oncologist doing any surgery for any tumor suspicious for any primary. He has to biopsy the tumor. Whatever, even if you know the primary. And for the presentation that said speak about, I think it's very clear for the examiners. There is like buzzwords and buzz questions. They will ask you what are the primary tumors they send metastasis to the spine or to the bone. What is the presentation of the patient? Why it's transferred to the spine before the limbs? So you speak about Boston venous plexus. They will ask you about if you reach to this, and for the spines, they will ask you about Kohashi score. It's a prognostic score to tell you about the patient, the survival of the patient, that if he's less than 6 months, more than 6 months. Then you will take about palliative treatment, radiation, then decompression, fixation. He will not go through more than this. This is the buzzwords for the questions only.
Okay. Xray, you were going to say something?
Now, my question was what, so I got you. I mean, I'm almost, Mustafa answered the same thing. I was about to say exactly the same. That's fine.
Fine, good. Okay, guys. Again, you have to take each case as it's presented to you. Don't have like a rigid answer, like every time you have to delay the management until you get a biopsy, because a lot of the time, well, the MDT will tell you, no, we are sure this is breast cancer, just go ahead and do something about it. And sometimes you can do the biopsy at the same time. For example, you've got a neck of femur impeding fracture, and there are mets there, and the patient is known to have breast cancer, for example. You will go ahead and do stabilization and take the reamings and send them as biopsy. Some people, you know, there is an impeding fracture. A person in our trust, we don't delay the operation for that. We just discuss it in the MDT, ask them, how sure are you that this is breast? And if they say, yes, we are, then we go ahead and confirm it with the biopsy, because that doesn't change the management in general. Yeah.